All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are actually in Troy. It's been a while.
Feels good to be home.
Yeah, it's been a while.
Home field advantage.
It's been a while since we've done a podcast here in Troy. We've been traveling a little bit, and so that's exciting. But today we are here in Troy because we are so excited to have not only Erica Boland, which we're getting into in a second, but then Lindsay Muma teaching the Perinatal Manual Therapy course, or MoveMentors, right? That's you guys' collective name, and man, the first half of it has been amazing. Hit some good functional movement. Talked a little bit about the pelvic floor. I'm excited to learn more. But anyway, it was a really awesome first couple hours. So anyway, we're sitting down with Dr. Erica Boland. So I've gotten to know Erica kind of from afar, honestly, through Lindsay, through Brett, through your Instagram, stuff like that. But it's been awesome to get to know you in person. So Erica treats in West Salem, Wisconsin. Her clinic is Cooley Health. Cooley Health. You're a Palmer grad. You're an MPI rep. You started the MPI club at Palmer. Or what was the story with the MPI club?
So I started going to MPI before I matriculated as a chiropractic student because my husband was ahead of me in school. So MPI is part of the reason why I switched to chiropractic.
Gotcha.
Nice. I was in nursing school at the time.
Beautiful. So not only are you a doula, you're a student midwife,
yes.
But you're getting closer to that, which that's got to be one of the crazier connections or combinations of skills that I've ever heard of, but it fits so good together. I mean, it's absolutely amazing. So maybe talk us through that decision to get away from nursing and go into chiro, and then doula, midwife, all that kind of stuff.
Yeah, so when I was in nursing school, my experience with our first birth was less than ideal, and that kind of propelled me to want to do or provide better for other people. And so I wanted to be a midwife, and I only knew of the route of going to school to be a nurse and then be a nurse midwife. And when I started the nursing program, I didn't really realize that at the time it's a hoop you have to jump through, but I was really just learning how to medicate people and how to not over-medicate them. It just felt so much like, here's the drugs that they can take, here's what you shouldn't mix. And I was really defeated and just really didn't like it at all. And Kyle, at the time, my husband, was at the time in chiropractic school already, and as boring as origin and insertion are, I was studying that with him and getting excited about that over what I was learning in nursing school. So I joke, it's not really funny, I was at a private college and spent more on 1 year of nursing school than he did on his entire undergraduate degree. So kind of an expensive lesson. But then what happened is we got pregnant with our second, and the midwife that I wanted to use, we couldn't because of insurance, and she said, I'll be your doula. And I was like, I don't know what that means, but yeah, sign me up if you're going to be there. So through her, I learned what a doula was, which is like an advocate, emotional and physical support. So I thought, this is perfect. I will do chiropractic and be a doula, and I will be able to have the best of both worlds. And so I thankfully had Kyle going before me and introduced me to MPI. That's where I met Muma. I went to my first Adjustathon in first try, and MPI really and DNS really paved the way that I practice. It's just the most what I use, and now I get to see as a student midwife how that also transfers over into midwifery care, which is really cool to see. So it just felt like the next step from here. I am a birth addict, so
What's missing in Western medicine? I mean, what are you feeling? What's a void that you guys are feeling that's not currently being done, would you say?
Yeah. Oh gosh, there's so much. There's such a disconnect between providers, and I see this in the birth world because it's where my head is at, right? But you can look at GI, you can look at endocrinology, you can whatever. It's this whack-a-mole approach of, let's treat this, but never actually come together and treat the whole patient. And so one of my greatest goals is to bring the people on the birth team, and to me that's anybody caring for a pregnant or postpartum person, to bring them together in communication and help them communicate better for the patient's benefit but not get lost in transition. And so we've got this society that treats pregnancy as this sickness and disease, and it's really like there's so much decided based on policy, which boils down to politics within the hospital system, that isn't really actually evidence-based as much as just,
But people
risk
think
assessment.
it is kind of typical, yeah.
So, and then the postpartum disconnect is what is like really near and dear to my heart. So we've got ACOG that now recommends an increased amount of postpartum visits and including physical and emotional support, but the system doesn't support that. There's not time for the providers to do that. So without placing blame on any one particular provider, it's like, it's our job to communicate like, hey, we're the musculoskeletal specialists and we can help your patients with their core and their pelvic floor. And realize that team approach so that there's nobody feeling like they have to do it all, because when that happens, then the patient is who gets lost in that transition.
Right.
What about what avenues does then the midwifery open up to fill that gap for you that maybe you didn't have before with just the doula and the chiro?
Yeah. So, I mean, outside of just getting to catch babies, I am able to provide a more in-depth prenatal and postpartum experience. So I want to continue to practice as a chiropractor and provide adjustments during prenatal visits and postpartum visits and whatnot. But using all of my background and, you know, how the body moves and my training as a doula and all of that to sit down and have a 30 to 45 minute prenatal appointment with a person so we can actually talk about what's going on in their life, what their fears are, what their hopes are, how they want this birth to be, help them better understand the importance of moving their body and eating well for themselves and for their baby, and like really connect with the human instead of the standard of care in a prenatal visit now is like listen to baby, weigh the pregnant person, take a measurement of the fundal height, blood pressure, pulse, all that, and answer questions if they come up, but it's 10 to 15 minutes and it's just not enough. And then we have the worst birth outcomes for moms and babies of any developed country. We spend the most money on prenatal and postpartum care with the worst outcomes. So
What are the biggest misconceptions, do you think, like on the pregnant patient? Like what are the things that like the world doesn't know but that probably should know?
So what comes to mind for me when you ask me that is like the physiology that happens during pregnancy actually sets you up to be what I would say a higher level athlete. And so not everybody would consider themselves an athlete, but it's this time where you have like the extra blood flow, the extra oxygen, your body is this powerhouse. And so if you use that to fuel you into continuing a movement practice or starting a movement practice or whatever, you can actually make so many health gains during pregnancy, and it's viewed as this like fragile sickness, right? Mm-hmm. And then postpartum, what happens is we just push people back, right? Like it's quick, it's rushed, there's not enough slowdown. So flipping that on its head, I think is a challenge, but also I think we've come a long ways with it too. So I live in a bowl and the people around me understand and they practice that way, and for the most part, but I hope to be able to like continue to educate other providers on that, and like just the capabilities of a pregnant person and the powerhouse, and it's just absolutely amazing for them.
Is there a sweet spot? So we have a group over here where we're going to treat you like a delicate little flower, and then I feel like, then we'll see somebody deadlifting 225 pounds and they're 8 months pregnant. I'm assuming that at some point we got to be careful for the people that are, on this far into the spectrum over here. Could you comment on like what the right amount of activity is? And I know every case is normal, but I'm assuming like anything in life, there's a glass of wine is healthy, 2 bottles is not good per night. So I'm wondering, is moderation at play as far as activity?
For sure, and it is like anything else in our profession. It's not cookie cutter. There's no easy answer. So that person, it depends on how they're training. It also depends on how they're feeling. And so you can take someone that is a high level athlete and then they get, you know, your balance changes, there's biomechanical changes and whatnot. And so at some point, especially later on in pregnancy, it's like, okay, is running, you know, if you're going to continue to compete or whatever, is it what is best for you and for baby? Maybe not. How can we get that same stimulus so that you keep your fitness level and without injury? Okay, so then you just break it down to what their sport or whatever it may be that they're doing. Like break it down to what they need to continue to be on that forward momentum. And then during the prenatal time, during pregnancy is when you're also communicating that postpartum time is your recovery and your rebuild and your slowdown. So most people think like, oh, don't get your heart rate up above such and such when you're exercising during pregnancy, and there's no good research to support that. The best thing is your hydration, and then making sure that baby returns to movement within 30 to 45 minutes of activity. But you can certainly measure heart rate variability, but even that is such a blanket statement because it's different for everyone.
So we don't really have to worry about harming the baby at all with being active throughout the whole pregnancy.
Yeah.
And I know that answer. I just wanted to have you comment on it.
No.
Because honestly, for us, we know this, but I feel like the patients, you know, like they don't know. I mean, they ask us all the time, you know, like,
right.
So are you saying it's not good for me? Because like most people are like, at this point, I don't care about myself. I just want to be sure that the baby's going to be healthy.
Right.
Is running still going to be healthy for the baby? Is that still? But you kind of answered that.
Yeah. So the baby gets in the placenta. There's like increased oxygen to the placenta. You can't ask for much more than increased oxygen supply, right?
Ever.
To an extent. But the baby gets so much benefit from movement. And of course you have your extremes where it's like they're under eating and overworking, like, you know, that sort of thing. But in that scenario, in a pregnant person, typically the pregnant person will be the one that gets the brunt of that, and it's usually postpartum because the baby will get all the nutrients. It's all shunted to them. Of course, there's different scenarios where there's like high risk, you shouldn't do this, that, or the other thing, but I think the biggest misconception is bed rest, and there's no presentation, diagnosis, etc. That bed rest actually helps with. In comparison to, you know, if you've got placenta previa, for example, where placenta is lying over the cervix, which can move and change as the uterus grows, but if it doesn't, then you have to have a C-section. So there's different things. There's like no intercourse, or some people will recommend bed rest, or some people will recommend no activity. And there's not any research to support that they need to completely avoid activity but monitor for symptoms. Obviously, if you have bleeding, then you need to cut back and you need to figure out what that is. You need to go see your provider, whatever.
We used to say that we only use bed rest for fractures, and now even with fractures now, we're encouraging movement and loading. So it's kind of funny I don't know what bed rest is good for anymore. You know?
I just read a research study and I was like, this is insane. There is a direct correlation in upper body strength in lowering cesarean section rates. And I was like, I have to look more into that, but I think it was a study on overall fitness, but then specifically training upper body strength helped to lower the cesarean rate.
Wow.
In this studied group, which is pretty powerful.
Which the United States, correct me if I'm wrong, is like one of the worst for C-section rates. As far as we do more C-sections than any other developed country. Like what's to blame for that? Do you have any good answer?
Policy. And I mean, so you and I were chatting about this earlier. So it's like we had 2 of our babies in the hospital, 2 of our babies at home. And the first birth, I had absolutely everything except for a C-section. I had an episiotomy, we had vacuum, you name it, everything. He was in the NICU because all the things except for a C-section. And still, even though I had educated myself on why that probably happened, and they'll teach you in a childbirth education class inside the hospital, the waterfall effect is what it's called. Every single intervention that you have puts you at greater risk for needing the next intervention. So we have so much intervention. So even though in my next pregnancy and birth, I knew that I could piece together the puzzle, like a lot of these things happened because of the waterfall effect. I still had this question, like, what if I really needed all that? Like, what if I really needed all that for my baby to be safe? And at the end of the day, the fear of, well, I don't want to have a home birth or a birth center birth because what if something happens to the baby? We need to be real that there's a lot of things that happen inside of a hospital that don't need to, and that are happening simply because of the policy in the system. And obviously they have a time and place and they're needed when they're needed, but our cesarean section rate should be between 10 and 15%. It's at 31%.
And that was one of the main things that I wanted to ask you was there's a misconception of doing a home birth, for example, because the thought is, well, we'd want to be around a NICU in case something were to go wrong. And you were touching on it here on your previous answer, but so could you comment more on the people that are considering home birth and maybe like comfort them and let them know that might be a viable option?
For sure. So a midwife is trained not only how to, first of all, you should be trained in neonatal resuscitation. We come with oxygen, medicine, whatever, in case of emergency, in order to have enough time to transfer, right? So depending on where you are in the country, some people are far away from a hospital, but their only option is home birth. You've got different scenarios. The majority of births are physiologically normal, right? And healthy, and they're fine and they go well. Sometimes intervention is needed. And I think that we have this mindset that most of the time intervention is needed. So I should be somewhere where I can have access to that intervention. And what that leads to is more intervention because you have ease of access to that intervention. So I was the person that was like, no, I'm not having my babies at home. It's like a hippie, crazy crap. That was me for sure. And now I'm going to be a home birth and birth center midwife. Like full circle. But a lot of times it's not only, it might more so be the partner that's nervous about that too. But we're also trained how to risk assess people during pregnancy to know if they are good candidates for home birth or not. And that takes humility on the part of the midwife to know when you need to refer them to high risk.
What percent would that be? Like,
it's
I mean, ballpark.
low. I couldn't even give you
less than 5.
I would say less than 10%.
Okay.
Of births that
As far as like costs on the healthcare system, I'm assuming home births help that, correct? Like, so I mean, that would be another reason on the other side of it for...
Yeah, so if you, let's say, we'll use the example for the birth center that I'm at right now. If you were to pay full price, I think their full price is around $4,000. My sister just had a baby at the end of July. Her hospital bill was $27,000.
Wow.
The answer to that question is yes, then.
Yeah.
Is it becoming more mainstream? Are these birthing centers going to be starting covered by insurance? I mean, like how much percentage?
I'm in Wisconsin. So Medicare and Medicaid dictate a lot of things in the insurance world. And so in Wisconsin, Medicaid does cover out of hospital birth. It's not at anywhere near what it should be for the rate, but it does cover it. And so there are some insurance companies that do. What's interesting is when you start to get into the politics of all of it, even most high deductible insurance companies will cover if you needed a cesarean section, then they would fully cover it no matter what. And so you start to look at where, if you start to trace the money, it's always pretty ugly.
Yeah.
What about, so the most commonly asked question for postpartum females in a DNS seminar is about diastasis recti. Yeah. So educate us for 3 minutes on the current thoughts of diastasis recti, whether or not, what we can do about it, things like that.
So diastasis recti happens in 100% of pregnancies. It's physiologically normal. It's the way that our body adapts to expand to allow for the growth of uterus, baby, everything involved, right? Your body has to do that so that you don't tear tissues, etc. It's physiological. What's happened is now that there's more awareness about diastasis, it's becoming like this hyper focus of what it looks like and like we need to treat it. And what research is saying is it's not really correlated to low back pain like we once thought it was, and it isn't correlated to greater incidence of incontinence or prolapse like we thought it was. But as providers, we can use it as a tool to assess how is the patient stabilizing. And so I use the like DNS-based movements with the functional progression. I use that with all of my pregnant and postpartum patients. So they can feel and see that when they activate their core properly, they create more stability, which means that there's going to be a little better approximation of those tissues. But the other indicator that diastasis gives us is their overall general level of health too. You have better tissue repair if you're healthier and whatnot. So we can look at it that way too. And I get people that are hyper focused. I mean, 2 finger widths or less is considered normal, but then there's also depth to it as well. And your diastasis will stay wider throughout your breastfeeding journey. So let's say someone has a baby, they're breastfeeding, they get pregnant again, they're breastfeeding. After they're completely done breastfeeding, the estrogen levels change, and that increases the healing that happens in the tissues, which directly correlates to a decreased width and depth, or should anyway, of the diastasis.
Well, I think too, we have in our older male patients, they'll have a diastasis recti, which is officially a hernia. You have like a tear in abdominal tissue because of hormones and other things during the pregnancy. A lot of times these structures, including the fascia, muscles, etc., they're just under massive stretch.
Yeah.
So I think sometimes like the females feel like they have that hernia where they might not actually have the hernia.
Right.
They just have kind of a looseness in the connective tissue. What % would you say of people who have diastasis recti postpartum, do you think need treatment to help them, or do you think it's not a treatment thing, or what would you...
I would like to see all people be able to go through a foundational movement.
Right.
And that would be the focus. And when they do that, they will see their diastasis improve.
Right.
We've got a pretty sedentary population, and just movement in general, especially if it's functional, is going to benefit that. But honestly, I would say that more thinking about like, okay, don't start doing this sort of thing until 2 weeks postpartum, and then, maybe add a little bit more in about 6 weeks postpartum, 12 weeks, and then you're starting to look at 6 months out and just increasing your strength training from there, and getting into a strength training based program will help with that diastasis too. But like you said, this happens in older males. It also happens in females that have never had kids, will never have kids, whatever. It's it's for us as clinicians, we can look at it and like, okay, there's a little bit of a leak in the system. How can we teach them to stabilize better? And the more that we have talked about it, I think the more that patients have gotten this like, oh, I shouldn't have this thing. It should be closed by now. It should be back to normal. And it's going to be different for everyone. But as long as you're doing some sort of functional movement, and like I start people out at 2 weeks with the functional progression, as long as you're doing that, you're on your way to moving better. You're going to have less overall core and pelvic floor.
So the focus with them isn't really, I haven't seen you in a month. Let's re-audit your diastasis to see if it's doing better. Instead, it's more on, let's just continue with this functional movement program. And if we do a good job there, then the diastasis should be...
Yeah, I want to watch you move, and I want to see you move, and I will assess it at a follow-up visit more because I want to feel the integrity of the tissue,
right,
and their habits for creating brace, what that looks like for them. But I think it needs to be more of a like clinician tool than it is a patient for the patient to hyper focus on.
Eric, over the years, you and I, we always email back and forth or talk about, current research on the pelvic floor, and you're definitely more in that world than I am. What are the current thoughts on pelvic floor function and dysfunction?
Yeah.
Because the thing that's a little bit confusing is the people act like, if the inner core of muscles is basically like a can of soda.
Yeah.
And we talk about the respiratory diaphragm, and I mean, it's been proven. I mean, with intra-abdominal pressure and respiration, I mean, the diaphragm is moving quite a bit. And when we go to talk about the pelvic floor, it's always like we're all still a little bit unsure of exactly what the pelvic floor is doing. What's the latest and greatest on the pelvic floor?
So when the diaphragm and pelvic floor, when the diaphragm moves down, the pelvic floor moves down with it, and then upon exhalation or relaxation, it should return to start position. And I'm careful to say it that way instead of say move up, because otherwise people think that they need to draw up and in. And so this is in like full circle back to even the beginning of the conversation, is you've got a lot of providers that aren't trained in musculoskeletal care, including chiropractors, but especially midwives and OBs, that this isn't their background. They didn't learn this stuff in school. And so the common word that you think of when someone says like, what should I do for my pelvic floor, is Kegels. And so what that is single muscle group activation that's increasing tone in the pelvic floor. And what we're finding is the most likely cause of pelvic floor dysfunction is too much tone in the pelvic floor. It's hard for people to wrap their head around. You can have trigger points and hypertonicity in the pelvic floor and still have incontinence or prolapse or pain during intercourse or, change in orgasm or whatever due to that. More so is what we're finding is more so than too little activation. You can probably, when you think about like generally, especially the last 2 years, the population is a little more tense. And so that, especially for females, but also for males, is an area where they hold a lot of that tension. So.
And I heard you say this morning, you don't use a lot of verbal cueing. Obviously you don't use a Kegel, but you don't use like female and male cues very often in your training with these patients. To cue activation, you mean?
Yeah. We work on relaxation first. So a lot of it comes down to breath mechanics and working on getting a full core breath down low and in the sides. And then something that I picked up at DNS is, having them like straddle sit on a rolled up yoga mat and breathing and feeling that their pelvic floor automatically relaxes into that. As soon as you say your pelvic floor should drop down, you've got people bearing down instead of, just relaxing.
So what would the cue be once they're sitting on a folded up yoga mat?
So you sit all the way back up against the wall and you like spread your cheeks so that ischial tubes or your sit bones are on each side of that rolled up yoga mat, and you just fully relax. You got to relax your belly, you've got to relax your bottom, and when you take a breath in here, you should feel that drop down. Move down, lower, relax into, whether it's the yoga mat, whether you're sitting on a physio ball, because there's so much tone in the pelvic floor or hypertonicity or trigger points. Once you get used to that, you can actually use a yoga block and set it, and it's not comfortable at first, but it is a way to help release those trigger points. I am a big advocate for people actually feeling internally on themselves to feel. You can like palpate around in a circle and feel where those trigger points are in the pelvic floor, and then same way that you do when you do a diaphragm release or any other trigger point release, you just hold tension and breathe into it, and then it can help to relax that. So,
and as you've gotten better with this and you require less internal work, I'm assuming is what you've learned as your career's gone along.
And so when we were talking in the seminar about, does absolutely everyone need a pelvic floor PT internal appointment postpartum? The good majority could probably use it, but I think a lot of it is just bringing your awareness to that area, because there's so much disconnect that happens. And then if you add any sort of trauma on top of that, and scar tissue after birth, if there's a tear, episiotomies are really rare now, thankfully, but scar tissue heals thicker than the tissue that was there before, and so that's also a really good way to mobilize that scar tissue, because that will start to cause issues down the road too if it's not taken care of, just like any other scar tissue would.
For our male listeners out there, the research is pretty telling. So 20% of postpartum females will have leaking with coughing, sneezing, laughing. So this is like a lot of our patients. And maybe if we don't ask the right questions, maybe it's a little bit more awkward coming from a male to a female sometimes in a patient encounter. But my guess would be we're severely undertreating these patients.
For sure. And honestly, two things. One, even me being a female and a doula and like, you know, they know I've got 4 kids, this is what I do. It's still sometimes pulling information out to you. Any sort of incontinence? No. Even weight? No. How about when maybe just a little bit, you know. So if there is any leaking at all, I don't want you to feel like, oh, I'm broken or whatever. It can certainly be helped, but it isn't something that you have to live with. And I think that hopefully we're breaking through that stereotype. But as a male, so if there's male chiropractors listening to this that are working with postpartum or prenatal even, because obviously the best treatment is prevention, I know that if you are doing those functional based movements, if you're assessing breath work, etc., you're helping that automatically. I do think it's a good idea to ask those questions, but you know, you can explain like, hey, do you have any of this going on? Any incontinence with coughing, sneezing, laughing, jumping, any running, whatever? And if so, I want you to just make note of it for when we're doing our treatment plan, if you notice any changes, because as we change what your habits are for your core stability or, you know, whatever, it should improve.
Well, you had that slide today. I mean, you have your obvious ones we all know with pelvic floor dysfunction, but there were some other ones that people might not be thinking of, like constipation was one of them.
Constipation, diarrhea, both going back and forth from constipation and diarrhea. There's like lack of orgasm, decreased orgasm, hyperorgasm, and someone was talking about, or when Muma was talking about her trigger points, and someone said, this might get weird for a second here, but someone said something about being ticklish, and she's like, yeah, it's, you know, it's like one step away from pain. And so it's similar, like hyperorgasm sounds like who wouldn't want that, except for you're probably on your way to more pain eventually if that tension stays there. So
too much of a good thing.
Exactly. Well, I think you had a great thought too about, you know, we always talk about how intricate the body is. It's so connected top to bottom, and you were citing a couple studies on the jaw's relationship to the pelvic floor. So it's not just even having tension and tone in the pelvic floor as a standalone, but it can be generated from other areas, or you can access it from other areas. So I think to your point of being a male and having, you know, accessing the system from different areas, I mean, just being a good assessor can get you to there.
For sure. So when I had said, like, you could go take Brett's TMJ course and know that when you're treating your patients' TMJ issues and utilizing those tools, it's very likely that you're having a positive impact on the tension that they're carrying in their pelvic floor. And when I was in Prague for DNSD, Pavel was checking, like, he was doing something with my shoulder and scap. He had me laying face down on the table and was doing all these things, and he came down and like messed around with something on my foot and came back up, and my range of motion increased drastically. Part of the room was like, oh, what did he do? What's the trick that you do on the foot in order to make shoulder mobility better? And the point was, you can work on the foot and you're going to change what happens throughout the system. So
we're sitting underneath the master, right? I love it. So Brett's amazing headache story that he tells all the time, and I think that's like a true savage in the treatment room. Is exactly what you're saying.
Yeah. So and I was talking with you guys a little bit before, but it's cool to see. I think, you know, obviously starting with MPI before I even became a chiropractic student gives you that little advantage of increasing your palpation skills. But that's where I learned to palpate. Even though I, you know, spent how much money on a chiropractic degree, I learned to palpate best in MPI club and in weekend seminars and whatnot. And so it has been awesome to see that translate into doula work and midwifery care, and my ability to feel baby's position, which is, you know, you can get into if I should even say that out loud or not, but my ability to palpate the position that the baby's in and then feel where there's actual trigger points in round ligament or actual restrictions that are potentially...
Whoa. There's no intertestal reliability. Whoa, no, we can't do that.
We can't do that. How dare you?
Yes, right.
That's a trigger for us.
nobody touches their patients anymore more than we do. So that's an art, right? And so I am oftentimes catching if baby is breech or whatever before a provider does, because my palpation skills are greater, because that's what I do for my job. So yeah, it's cool to see all of the like tools or experiences or whatever come together in that, to blend that.
We interviewed Kevin Christie, and he calls it skill stacking.
Okay.
Right. So you're exactly what you're saying. Your palpation was the foundation, and then you're just stacking skills that then make that even better and better, which is so awesome to think about. I mean, that like gives me goosebumps to think about how cool like these foundational things that we take for granted sometimes make us so much better. I mean, we talked about, you know, the art of palpation in Western medicine is somewhat going away even.
Right.
You know, like that used to be one of the things that you do with patients, right? You palpate, percuss, you know, like
great doctors.
That's just one of those things. And so,
sure.
you know, to say that this is a chiropractic thing to palpate is just ridiculous. I mean, the best clinicians in the world are going to palpate. It might not be the same way that us three palpate, but they're using some sort of tactical tactical input. So that's just, it's a cool thought.
Yeah.
Awesome. We didn't talk about positioning of body segments for activation of the pelvic floor. So I'm assuming rib cage pelvic positioning, that's important to get the right activation that we want.
Right, the right activation and the right relaxation too, really, So when you are in that parallel position, like rib cage stacked over pelvis is where you're most stabilized, I guess. But then having the ability to create and maintain stability as the trunk rotates, bends, flexes, etc., all of the above. When you have better connection or correlation or synchronization, whatever you want to call it, between diaphragm and pelvic floor in that position, you have better access to using it in all positions. So it's no different than like, you know, breath being such a prime example of how if we can normalize the breath from there, we can, or make the breath more functional from there, we can help all other movements. So
we know too, like if we're in a deep squatted position and we have to initiate to get out of that position, that you have no choice. You have to activate your pelvic floor as long as the right physiology is in place. Is that a good place to still train our patients for pelvic floor? I guess what I'm trying to ask is, in your progressions, are you like going for that? You know, like sounds like in the beginning we're working on respiration, relaxation. Is it like advancing to another level, or that's not how you think about it? Okay.
For sure it is. Okay. The squat is one of the best ways to train pelvic floor function. And so with the functional progressions, they're like supplements to movement, the same way vitamins are supplements to nutrition. It's like, yes, it's good to, it's the way we were designed to move. And so you can use that as a tool to reset when you come into, you know, any fail point, whether it be postural or in a workout. It has to happen to progress. And then you remind your body, like, this is what we want our main primary movements to be, or patterns to be. But we have to progress further because in order for your pelvic floor to support you in the demands that you put on it, then you need to train in those positions, in those upright positions. And postpartum, so there's like, you know, the like don't lift more than 10 pounds if you had C-section, or if you know, postpartum, whatever, like a lot of people hearing that and their child weighs almost that much. And so if we can get in this more in this mindset of let's train for strength and stability and endurance and the marathon that birth is, so that also you can recover better postpartum, then we've got a huge potential to drastically decrease pelvic floor dysfunction instead of the like just uphill statistics that we're seeing coming out for projections for where pelvic floor dysfunction will go if we continue to just do nothing or tell people to Kegel or whatnot.
Are there any other favorite positions you use besides squat or low kneeling? I mean, is there any surprises out there? I think most of our listeners are going to know the obvious ones, but is there anything you like in particular?
I'm trying to think if there's anything specifically. I mean,
it's always kind of hard because, like, of course, every exercise can be used for everything, of course. But then sometimes, like, you have your 45 minutes behind and you got to have an effect here. I go to these. So typically, you know,
if we can get some single leg work in, and then also triplanar, so making sure it's in all three directions, but getting some single leg work in for the posterior chain especially is when the glutes are more stabilized and more able, if we're talking about moving beyond the basic core functions, the glutes have a big role in how the pelvic floor can or does activate and support the body. So even something as simple in the sagittal plane as doing some good mornings or doing a single leg deadlift or a single leg, whatever, training for that stability piece, because then as the tissues start to change, whether it's pregnancy or postpartum, as that starts to happen, you have a higher propensity of being able to flex and flow with the demand of the change in center of gravity and all of that. Mm-hmm. There was one I can't remember it. It left my mind. I was gonna take.
Well, while you're thinking of that, I think it's really critical to understand, and we learned this from Paul Hodges, Sapsford, and others, that this inner unit of muscles, they basically all work together.
Yeah.
Like, you're not going to separate transverse abdominis away from pelvic floor, away from respiratory diaphragm.
So why are we trying with?
Yeah, exactly.
And I'm glad you said that, because that's when you said Hodges. So some newer to me research that's coming out looking at how transversus actually works, because we get pretty hung up on activating transversus as well, and like showing that it doesn't activate together, like bilaterally, it doesn't activate at once. So in order to better train the transversus to support the core and pelvic floor together, and that synchrony that you're talking about, unilateral movements are key. So even something so simple as farmer's carry or windmill or whatever, just doing that single side activation. And so I'll get patients into, like, if you pick up a heavy kettlebell or whatever, just have them feel what happens right here. They have to activate in order to carry a load, including their own body. We just get really lazy with that sometimes. So having them adding that weight in so that they can feel what that feels like, and then taking that into day to day.
Yeah, I think that's such a good point. I think, like, in this journey, if we've learned so much about the abdominal wall, we've had Hodges, we've had Stu McGill, we've had Collage really contribute a lot to what we know about core function of this day. And it's just like every moment of our life that we're up and about, you're having to stabilize, respire, and maintain continence. That's a lot to ask for, these muscles to do. So it's very delicate. It gets disturbed very easily, especially in that pelvic floor population or the postpartum population.
Yeah.
So.
Sure.
What about, we're kind of getting towards the end here. What's in the most perfect world? Let's say a pregnancy is going great. What's your treatment plan for that pregnant patient? Pre and post.
Okay, so as a chiropractor, you're saying?
Yeah,
okay.
yeah.
So everything's going great. I will see them once a month until so let's say they came in to me. Sometimes I'm the first person to know that they're pregnant. So at the very beginning, I see them once a month until the last 6 weeks. We go once a week. Sometimes just before that, we'll start to go every other. It depends on what's going on. Mostly, honestly, with their stability and then and symptoms. And then once a week for those last 6 weeks, because you're technically full term at like 37, 38 weeks. So we're preparing the body for birth and postpartum healing. So then postpartum, 2 weeks postpartum, I definitely want to see them. And if they need something before that, we try our best to do a home visit. Some people, if they need it, because some people don't want to be out and about, and that's normal. Like, all the appointments that are scheduled right away postpartum disrupt breastfeeding, relationship, and everything else. So then 2 weeks, and then I see them once. So starting at 2 weeks postpartum, I see them once a week for a month. Then I go out 2 weeks, and then as long as everything's going okay, then I go out a month. And now the chiropractor Dr. Hallie that works with us, she has the Foundations of Strength class that she runs. And so what we're doing postpartum is getting them ready to go into that Foundations of Strength class. Then we have a women's strength class that they can come into after that if they want, or they can go, it's like the return to moving the way that they want to move, but doing it well, because it's all about finding what they love to do for movement so that they can stay active.
It's refreshing hearing her treat patients, right? Because there's such a stigma, especially with chiropractors, that we treat patients too much. But everything that we've said in this entire podcast, you can understand how difficult of a system this is to assess and to treat. And so you need to see your patients in order to have an effect on them.
Right.
Would you not agree? I mean,
I absolutely. And when I talk about this, we haven't gotten to that point in the seminar, but when I talk about this in the seminar, and Brett, I honestly think I remember you talking about this in MPI when I was a student and coming out being afraid to overtreat because there is such a stigma.
Yeah.
But in that was both my husband and I. But your patients they come to you because you're the expert to them. They want to know what the plan is. So just the like, okay, we'll see how it goes and I'll see you and maybe
they're not coming back.
Right.
Yeah.
And so I'm honest with them. If we don't need all those visits, we don't keep all those visits, or if we're not seeing the right amount of change, then I need to collaborate. And I like to use the word collaborate instead of refer. I'm trying to use that more because it isn't, getting rid of the patient. It's bringing someone else to the team.
That's really good.
So it's just, I would say more so since I've gotten more into midwifery in the last year and everything, that I'm really more adamant about the timeline for care plan, and it's showing better results. So
that's great.
Yeah.
That's so awesome. Wow, what a cool conversation.
Yeah.
Do you have any closing thoughts, Brett, or anything maybe we didn't get to?
Can you just give us one good book in your world that really, textbook that...
We interviewed Muma, one of our first visits. So I pulled up her list
How
of...
many books did she give you?
She gave me us so much. So
exercising through your pregnancy is what came to my mind right away, because it's all research and it's really good research and it's really easy to read. So it's good for both you and your patients. Oh my gosh.
Is that Cram? Or
yeah, it's James
Cram.
Clapp.
That's right.
But Clapp and Cram do a lot of research together, and Catherine, I don't know, she always gets left off. I feel bad doing it.
Anyway, keep going.
So, and there's Active Birth is a really good book as well. We've got a whole library.
Catherine Cram.
That's right. Okay.
What was the other ones that she gave us? Yeah, Taking Charge of Your Fertility, Tony Wechsler.
Yeah.
The Fifth Vital Sign, Women's Bodies, Women's Wisdom.
You know what? The postnatal depletion cure. Okay, so speaking of things that are under-addressed, and we could do a whole nother podcast on this, but I will tell you that I read this when I was postpartum with our youngest. I was 2 years postpartum with our youngest when I read it, and it was really freaking hard to read. And so the guy that wrote it, his wife started going through like complete postnatal depletion, and so it's Oscar Sellerick, I think, or so. He started doing all this research on it and found that the most common time to see full postnatal depletion, meaning like a functional med disaster, basically, hormones are all out, everything, depleted nutrients, is 4 years postpartum.
Wow.
Right?
Wow.
That's insane.
Yeah, it is insane because most of the time there's another kid by then. So talking about stacking skills, you're stacking dysfunction.
stacking dysfunction.
Yeah, and then when Kyle, my husband, said he was going to go do training for functional medicine, I was like, are you okay seeing mostly women? Because I could refer almost all of my patients to you because it's a mess. So, and it's not treated in Western medicine.
And do you think it's a mess now because we're so unhealthy in the Western part of the world? Because you got to think that the human body wasn't designed to be dysfunctional 4 years afterward. So we've got to be doing something that is, wouldn't you think?
Physical
maybe not, but
and emotional stress. It's environmental toxins. It's physical stress on like our need to push people, like get back to work, get back to whatever, like,
or even to be a good parent.
Yes. All of it. So I think it's multifactorial for sure, but
okay,
perfect. I'm gonna go silence Brett's phone because it's the loudest vibrating phone in the world. Keep talking.
By the time you get there, it'll be done.
So yeah, that book was powerful for me to read. It was really validating for what I was going through at the time, so that was both good and bad too. Like I'm not crazy that I feel like, I was going to bed before my kids and they were like coming to tuck me in. I was just done, like just totally done. And I had started to have these sort of symptoms in 2010, and 2011 had a miscarriage, and then we got pregnant right away with the next baby. But so to be in 2018 and looking at like, holy shit, this has been going on for a decade.
Wow.
In comparison to when I had my first, in 2007, and like seeing, oh my gosh, this makes so much sense, and people think like, I don't know what's wrong with me. So I think that book is really good at just helping people understand why this is happening, some things that they can do. But yeah,
that's awesome.
Yeah.
That's great.
Wonderful.
Oh, I love it, Erica. Thank you so
me.
much for sitting down. I'm sure we're gonna have more conversations. That hopefully we're gonna get one with you and Mooma on together.
Sweet.
So that'll
Nice.
100%. That'll be off the rails.
Yeah.
The last time in Mooma's, Brett and her actually started off the whole entire episode by singing, and so
Nice.
I'm just glad we didn't do that with yours. So
Yesterday at the Palmer MPI, I went and spoke at their MPI club, and afterwards, one of the reps was like, "What happens when you get you and Mooma in a room together?"
Yeah, it's interesting. No, it's amazing. It's amazing. Well, it sounds like April will be the next time that we'll have one of these courses,
sure.
the MoveMentors Perinatal Manual Therapy. It's amazing. I mean, if you even have the inkling of treating women, especially women that plan on having kids, this would be a no-brainer course for you to be at, which majority of us would fall into that category. So there's really no one that shouldn't be here. Yeah. But Erica, thanks for being amazing.
Thanks for having me.
Thanks for being an
Really
educator, and we really appreciate you. You're so amazing. So guys, check out these books. They'll be in the show notes. And go back and listen to Mooma's podcast. It was really good too.
Yeah.
So all right, guys, have a great day. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.